to put, awesome, thank you. So I think it's important to put thyroid disease kind of in the context of, from start to finish. Mostly we're going to be talking about thyroid nodules rather than medical disease, because I think as surgeons, that's what, is more useful. So we'll start with a very brief overview of surge path processing for the new interns. We'll review workup of thyroid nodules. We'll talk about FNA and histology. We'll talk about molecular testing on FNA, which is really important. We'll talk about hopefully NIFT-P, which is kind of an emerging entity. At the end, we'll talk about parathyroid disease if there's time. So, just as a reminder, whenever something gets biopsied or surgically removed, it comes to us for gross examination as well as microscopic examination. We may or may not perform special studies, render a diagnosis, and hopefully impact treatment for that patient. And so on gross exam of this thyroid, we do serial sections. In this case, there's a cross section through the thyroid showing kind of normal on the top and bottom, and then this white tumor in the middle. We, of course, take these tiny sections for histologic exam. So how does that happen? The sections about the size of a nickel are placed into these plastic cassettes. They're processed in a number of fixatives. They're embedded in paraffin wax, and there they can be preserved essentially indefinitely for years, for decades. But to see the microscopy, we cut them on a microtome, place them on a glass slide, and stain them. So the common stain that you'll see is H&E, or hematoxylin and eosin, which is how we sort of look at everything. Hematoxylin is a basic dye, so it binds acids in the tissue, mostly nucleic acids, and the tissue in these cases is turned blue because of the color of the dye, or sometimes referred to as basophilic. Eosin is, on the other hand, an acidic dye, right? So it binds the bases in the tissues, and those tissues are referred to as acidophilic, or more frequently eosinophilic. So kind of the blue and the pink differences are because of those two stains. We may or may not do immunohistochemical stains, which of course are antibodies specific to various proteins in the cytoplasm and the nucleus and the cell membrane, or other histochemical stains, which are not specific to a certain protein, but kind of generically stain, for example, carbohydrates in fungal cell walls like GMS, any type of amyloid like Congo red, and then mucin. So just some examples of the stains we use in practice. In terms of the development of the thyroid, normally, right, thyroid condenses at the base of tongue as a condensation of endoderm at the level of the foramen cecum. It migrates down the anterior midline within the thyroglossal duct, and then it kind of solidifies, right, in the bilateral lobes and the isthmus across the trachea. It could leave a little midline pyramidal lobe, right? It could leave a thyroglossal duct, which can become cystically dilated as a thyroglossal duct cyst. It can descend too low, right? It can go into the mediastinum, and you may get substernal thyroid. So everything related to kind of midline up and down the neck and mediastinum. C cells, the calcitonin secreting cells, were originally thought to develop from neural crest. However, it was now shown that they probably developed from the pharyngeal arch system, the fourth pouch, or the ultimobranchial body. It is the last structure, right? The ultimate structure to develop out of those pouches. It's thought to sort of fuse with the thyroid gland, and then the C cells and the ultimobranchial body cell remnants kind of disseminate into the thyroid, mostly at the upper to mid poles. So any C cell neoplasm, as we'll see later, like medullary thyroid carcinoma, is going to be kind of in the upper thirds of the lobes because of that developmental pattern. So just as a reminder of normal thyroid, on the left, we have follicular cells, which are basically these balloons filled with colloid. Colloid is produced by the follicular cells and transformed into active thyroid hormone. The cells are generally very kind of cuboidal with bland round nuclei. This will become important later when we talk about carcinoma and the shift in the nuclear features. C cells generally are not visible on light microscopy unless they're hyperplastic or neoplastic. So this is an example of C cell hyperplasia. There's sort of these clustered groups within and around follicles. The cytoplasm is much more granular because it contains these kind of calcitonin granules, and the nuclei are equally kind of round and stippled and regular. So that's what the normal cells of the thyroid look like. Questions or comments yet? Cool. So thyroid nodules. So most population-based studies estimate that, over half of the general population has thyroid nodules, super common, mostly benign, but, on occasion malignant, and on occasion can be quite aggressive. Of course, these can be identified by palpation or visualization by the actual patient, by physical examination by a doctor. In today's day and age, very frequently we pick up kind of these incidentalomas on neck imaging, on CTs, on MRIs that the patient is having done for other reasons, for other head and neck cancers, et cetera. So pretty common to pick up kind of these thyroid nodules in that regard. The first step in the workup is ultrasonographic examination to determine the ultrasonographic features that are worrisome for malignancy. If the features are suspicious enough, the patient will undergo fine needle aspiration biopsy rather than a core or a tissue biopsy. And mostly these biopsies are directed by ultrasound, mostly because, nodules in the thyroid can be small, they can be multiple. And so if they're directed by ultrasonography, there is a better ability to target the nodule of interest rather than kind of blindly poking and disrupting other structures in the neck, et cetera. So mostly here, occasionally a thyroid nodule will get biopsied in clinic, an ENT clinic or an endocrine clinic by one of you all or by our cytopathologists, but more often these patients are referred to interventional radiology, during which time there is a cytopathologist present to look at the smear immediately and determine if the tissue is adequate for diagnosis or not, and say, I need more, no, I'm good, we need to do molecular testing. So it's a collaborative effort between the radiologist and the pathologist usually. If you remember, an FNA is, the cells are aspirated into that needle, they're kind of squeezed out onto a slide and spread. So you see a very thin layer of cells that are almost kind of detached from their surroundings. So the nuclear features and the cytoplasmic features in this case are going to be very important because there's only minimal architecture, as you'll see. Okay, so the American Thyroid Association has these nice diagrams of what is important to look for in thyroid nodules, ranging from, very low suspicion, circumscribed borders, hypoechoic, to, more heterogeneous, more vascular, very heterogeneous, very calcified, right? Microcalcifications, for example. So we kind of use these, the radiologists use these features to stratify nodules into risk groups. These ultrasonographic features then determine whether the patient will go for an FNA, depending on the ultrasonographic features and the size generally. There are some countries that don't really FNA thyroid nodules that are smaller than a centimeter. Here in this country, we're a little bit more aggressive and we poke and prod at everything. So, we have a lot of thyroid FNA. Once a cytopathologist looks at the FNA, they come up with a cytologic diagnosis. We'll talk more specifically about these cytologic diagnoses shortly, but essentially, these help determine the need for surgery. For example, if I can tell that the nodule is completely benign, there might not be an indication for surgery unless the patient is asymptomatic. If I can tell it's malignant, certainly there's an indication for either a lobectomy or a total thyroidectomy. And then there's this intermediate or suspicious category where the pathologist can't tell if it's benign or malignant. And so a diagnostic lobectomy may be needed. And then finally, the gold standard diagnosis is certainly histologic examination following resection for those indeterminate or malignant nodules. So essentially the goal of that FNA, right, is to determine therapy. A benign asymptomatic nodule can undergo just clinical observation. As we said before, benign but symptomatic may require resection just for symptom purposes. And those malignant nodules undergo resection. But as I said before, not all are obviously benign or malignant, and that's that indeterminate category. So the indeterminate category is sometimes labeled as atypia of undetermined significance, which is more likely to be nuclear atypia. I'll show you examples of what that means. Follicular lesion of undetermined significance, which is more likely to be architectural atypia, meaning tiny little compact follicles instead of larger follicles. And then suspicious for follicular neoplasm, which is usually also microfollicles, but very, 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 very cellular. And I'll show you examples of those. So we report verbal, like word diagnoses, benign, AUS, FLUS, but the Bethesda categories, some institutions also tack on the number. So like the 1, 2, 3, 4, 5, 6, 1 being unsatisfactory, repeat biopsy, 2 being benign, essentially 3 and 4 being indeterminate, 5 being suspicious, and 6 just being flat out malignant. The indeterminate groups, the 3s and the 4s, and sometimes the 5s, are the ones that are eligible for molecular testing on FNA in order to molecularly stratify whether these lesions are more likely to be benign or more likely to be malignant, because the visual eye cannot tell, right? So that's where the molecular testing on FNA comes into play in these so-called indeterminate nodules. So, you know, in these indeterminates, certainly molecular in our institution is and in many institutions is now becoming standard of care to spare patients surgery in benign nodules that you just can't see are benign with your eye, but you can tell are benign with molecular, or a quote unquote diagnostic lobectomy, right? For final gold standard histologic diagnosis. Lobectomies are usually used for definitive diagnosis of these indeterminate nodules, or treatment of low risk carcinomas that do not need completion thyroidectomy, meaning they do not need radioactive iodine therapy. So the only reason to do a completion, right, for patients with thyroid cancer is to take out all residual normal thyroid such that the radioactive iodine has maximal effect, right, so that it doesn't get sunk up in the remaining thyroid gland. Or total thyroidectomy, certainly for symptomatic relief for other medical disease like multinodular goiter, Graves, Hashimoto's, things that are refractory to medical management, or treatment of higher risk carcinomas that do need radioactive iodine, and you therefore do need to remove the entire thyroid tissue. So that's kind of overview of molecular and surgery. We'll get into a little bit more depth now as we move forward with some of these histocyto correlation cases. Does anybody have questions yet? Okay, so first I will go through some correlates from benign to intermediate to malignant. And so the first example of a smear that we're going to see is these kind of honeycomb-like sheets of very bland follicular cells with round nuclei and abundant, this kind of watery bluish material in the background is colloid. This is consistent with a benign colloid nodule. So if you think about it, when you stick a needle in it, what are you getting? You're getting the wall, right, of a large follicle. So you're kind of detaching a piece of that follicle. So that's the sheet on the left. And then you're also aspirating some of that colloid from the center of the nodule. So you're getting lots of colloid. And so histologically, it may look like this, right, where there are large follicles with lots of colloid and then these big sheets of cells or big walls of the follicles that result in those big sheets. So this would be a so-called macrofollicular adenomatous nodule, meaning the follicles are large or macro compared to the normal parenchyma, which here is on the top of the image. Follicular nodular disease is another diagnosis that's now being proposed for these instead of, just quote unquote multinodular goiter, because multinodular goiter is relatively non-specific. A goiter can be an enlargement for any reason. So we avoid, histologically, we avoid use of the term goiter for those reasons. But this would be a benign macrofollicular nodule. Why adenomatous? Because we can't really tell if these are truly clonal neoplasms, i.e. adenomas, or global, like kind of thyroid hyperplasias, histologically, right? The distinction between a neoplasm and a hyperplasm, unless it's carcinoma, right? Unless it's malignant, a benign neoplasm can't necessarily always be made histologically. It can really only be made on genetic analysis by things like mutation or clonal X inactivation, right? So we call these adenomatous because they could be adenomas, they could be not adenomas, but it doesn't really matter as long as we're not calling it malignant. So that's where that term comes from. Okay, what about your next smear where you have a combination of these kind of plumper oncocytic looking cells with granular cytoplasm, and then in the background, these really kind of small, tiny, almost not ghost, but they call them naked nuclei where they don't really have much cytoplasm. Those are lymphocytes. So in this case, we may be looking at more of a lymphocytic thyroiditis. And sometimes you can get pseudo nodules in lymphocytic thyroiditis, as you see here, / Hashimoto's, where the lymphoid inflammation, the germinal centers, even the follicles become kind of so pronounced that they can almost look like a tumor, but really it's just this kind of so-called nodular hyperplasia. So we see here chronic inflammation, very blue, with germinal centers, which are a little bit paler. We see oncocytic change in the follicles in the areas of inflammation. And you may be asking, okay, you talk about these oncocytes, well, what are they? So they were formerly known as Hürthle cells in the thyroid. We are now moving away from this eponymous term, one, just to get rid of eponyms in general, and two, because Hürthle didn't actually describe oncocytes retrospectively. It was thought that he actually described C cells. So we're attributing something to the wrong person, and we don't want to use a name anyway. So we're now going back to oncocytes. These are cells that have abundant granular eosinophilic cytoplasm because they are chock full of mitochondria. And you can see that on the electron microscopy on the right, which are these grayish kind of oval structures. They have large round nuclei with prominent nucleoli because they are very metabolically active. And so you can see here, these cells are really, really pink, right, with these nucleoli. So those are oncocytic change in Hashimoto's thyroiditis. The next FNA shows on the left kind of a few rare small clusters, not those big honeycomb sheets like we saw before. And some of the groups show significant nuclear membrane irregularities, grooves, and wrinkling. But overall, the specimen is kind of paucicellular. So this might be something that we would diagnose as AUS, atypia of undetermined significance, which is nuclear atypia. The other type of atypia that we see is, like I said, architectural atypia, in terms of the follicles now are really, really tiny. So you can see here 2 follicles with a very small center, but the nuclei around them, they're kind of clustered in this rosette-like structure. The nuclei are really round and they have fine chromatin, not a lot of wrinkles. So this might be something that we call follicular lesion of undetermined significance, or FLUS. Now, if you take those microfollicles and you spread tons of them out on the slide, very, very cellular, but the nuclei remain round and dark and regular, this might be something that we refer to as a follicular neoplasm, because now we have lots of cells. So it's a highly cellular specimen, but we can't really call it carcinoma because, as you'll see, we cannot make a diagnosis of carcinoma on a follicular neoplasm just based on FNA. We need the architecture and the surroundings. There are some cases that we can diagnose as cancer on FNA, and we're coming to that. But just as a kind of correlate between the atypia of undetermined significance, the follicular lesion of undetermined significance, and the suspicious for follicular neoplasm groups, our institutional rates of malignancy following these diagnoses are listed here. So FLUS, or follicular lesion of undetermined significance, has really low rates of malignancy. Usually these end up being adenomas. The AUS, the nuclear atypia, and the very cellular follicular neoplasm smears end up being, a 1/4 to 1/3 malignant, ranging from some kind of papillary thyroid carcinoma to even potentially a follicular carcinoma. So just to keep in mind what this means for the patient when you're counseling them. So those microfollicular neoplasms, either FLUS or follicular neoplasm on FNA, tend to be this. They tend to be essentially microfollicular adenomatous nodules, or follicular adenomas, meaning the follicles are very small, right? Which makes sense. And there's not much colloid. So that really recapitulates what you see on the FNA. Sometimes they have a capsule, sometimes they don't. They don't need to have a capsule, but if the capsule is there, that it kind of implies that you have to evaluate the capsule for what? For invasion, because the only way one can determine the difference between a follicular adenoma, right, and a follicular carcinoma is the presence of invasion, either complete transcapsular invasion, where the tumor inside, bulges through kind of like a mushroom here and invades the parenchyma on the opposite side of the capsule, or intravascular invasion. So here you can see the tumor kind of on the bottom left, and then this big plug of tumor within a vessel right next to it. So that's angioinvasion. And both of those qualify now as follicular carcinoma rather than follicular adenoma. Hence why you cannot make this distinction on cytology, and you need histologic examination of that capsule of that periphery. All right. Because follicular carcinomas enter usually kind of venous type of vessels, these can hematogenously metastasize to visceral sites like bone, lung, brain, liver, etc., which you'll see later is going to be in contrast to papillary carcinoma, which spreads more lymphatically. Okay, so that's follicular. Okay, moving on to smears that are predominantly only oncocytes. So now we have these large cells, again, with kind of granular cytoplasm, with these very round nuclei and these nice, super prominent nucleoli, but no lymphocytes in the background. So this might represent a Hürthle cell lesion or a Hürthle cell neoplasm. And just like follicular adenomas, oncocytic or Hürthle cell neoplasms are evaluated in the same way. They're basically like follicular adenomas or follicular carcinomas. They're composed entirely of follicles, in this case, follicles with oncocytic looking cells. And the only way to diagnose benign versus malignant is that periphery, that capsule. So this is an oncocytic adenoma versus an oncocytic carcinoma, right, where there's percolating invasion out into the periphery, but the cells within them look the same, right? If you go on high power in the middle of both of these, they'll look pretty much identical. Interestingly, it's now being discovered that oncocytic neoplasms are genetically different from non-oncocytic neoplasms in terms of they have increased numbers of mitochondrial DNA mutations, duplications of some chromosomes, and some sort of widespread heterozygosity. We'll talk later about the prevalence of RAS type of mutations in follicular neoplasms, which are slightly less common in oncocytic neoplasms. So just put that in the back of your mind for now. Okay. And then moving on, we have a very highly cellular smear with this kind of irregular pattern of cells that almost look like they're like horns or papillae. We have sheets of cells with really dense cytoplasm, and the nuclei in this case are a little bit irregular. They're a little bit elongated or enlarged. If you're lucky, you may see a true internuclear cytoplasmic pseudo-inclusion like here, and like here. This is pretty much indicative or diagnostic of papillary thyroid carcinoma. So this is a malignant diagnosis that you can make on cytology because of the specific nuclear features. So generally, papillary thyroid carcinoma is invasive or infiltrative with background stromal fibrosis. It is, by definition, as its name sort of suggests, composed of papillae, right, which are these central fibrovascular cores lined by malignant cells. In this case, you could see it cut in longitudinal section and then cut in cross section. And because these tend to enter into lymphatic type of vessels rather than venous type of vessels, they metastasize mostly to lymph nodes rather than visceral sites. Although, of course, a PTC can get into a vessel and metastasize to lung, but it is just much more rare. Psammoma bodies are also quite specific for papillary thyroid carcinoma. They are these concentrically lamellated calcifications that are thought to be kind of infarctions of the papillary tuft. So you can see psammoma bodies in carcinomas with papillary morphology in other sites of the body. For example, papillary serous carcinoma of the ovary is another common one that has papillary morphology and psammoma bodies. So it may be related to the architecture in this case, in these cases. I did want to briefly mention why we talk so much about papillary carcinoma nuclei And how did they get that way? So there's some theories on how these nuclei developed. One, that the nuclear membrane surface area increases and it doesn't know like where to go. So it starts kind of folding in on itself and creating these nuclear grooves or coffee bean shapes. If it grooves very deeply, it can form an indentation in the nucleus. If you cut a groove across, it might look like an indentation, right? And if you cut an indentation across in the right direction, lo and behold, it might look like an intranuclear cytoplasmic pseudo-inclusion, which is basically sort of an intussusception, right, of the cytoplasm into the nucleus, and you cut across it, and you see within the nucleus what looks like cytoplasm, all right? So that's a pseudo-inclusion, which is different from the quote-unquote orphan anti-eyes or chromatin clearing. Orphan anti-eyes are where the nucleus is white because there's nothing in it, because the chromatin marginates to the periphery. And so the periphery becomes very dark and the center becomes very pale, right? So that's the difference between inclusions and orphan anti-eyes and why they are that way. And you can see those on the cytology smears, and that will aid in your diagnosis of papillary carcinoma. So as a reminder of kind of the epidemiology and molecular genetics of papillary versus follicular carcinoma, we see here papillary is by far the most common. Both tend to be more prevalent in sort of young to middle-aged women, potentially related to either radiation exposure or iodine deficiency, depending on what part of the world you're in, but you can see both of these, sporadically, certainly. Genetically, these are mutually exclusive, where papillary carcinomas tend to have BRAF V600E mutations, which is the same mutation that we see, for example, in cutaneous melanomas, as well as RET PTC gene rearrangements, as well as some others, which we'll get to later. Follicular type of carcinomas tend to have mutations in the RAS genes, HN or KRAS, and rearrangements in PAX8 PPAR gamma gene. So these are the kind of top genes. For papillary carcinoma, this is generally good prognosis, tends to, as I said, spread lymphatically and is highly treatable because it's very radioactive iodine sensitive. Follicular carcinoma, if it really invades only through the capsule and not into vessels, this is a better prognosis for these patients. But if it becomes widely invasive throughout the thyroid gland or into lots of blood vessels, this is generally a worse prognosis for the patient, because now it's sort of out of the box. It can travel around the body and be somewhat harder to treat. Okay, the last type of smears I wanted to show you, which we don't see very often, but I think are very interesting to look at, are these more fusiform or elongated nuclei with really kind of wispy cytoplasm and very small kind of speckled chromatin. Sometimes you see these stromal chunks in the background, which I'm telling you here are amyloid, so you may already start to know what this is. Some of these cells have eccentrically located nuclei with very granular cytoplasm. And yes, this is medullary carcinoma. So that's another diagnosis of cancer you can make on FNA. As you know, these are functional. They secrete calcitonin. Usually papillary and follicular carcinomas of follicular-derived cells, right, are usually not functional. So these patients are not necessarily hyperthyroid unless they have something going on in the background. However, medullary carcinomas themselves are hyperfunctional. They do secrete calcitonin, and so these can be picked up serologically with high levels of calcitonin in the patient's serum. You can see these nice neuroendocrine type cells with speckled chromatin and a granular cytoplasm, and then this pink stromal material in the background, which is the amyloid. The amyloid is actually just conglomerates of calcitonin, but arranged in the amyloid pattern. So it will pick up the Congo red staining, for example. Medullary thyroid carcinoma most often is sporadic, about 3/4 of cases, and about 1/4 is thought to be familial. The familial ones tend to be multifocal. They tend to be in younger patients, certainly those with RET germline mutations. Kids with known RET germline mutations and MEN syndromes, right, undergo prophylactic thyroidectomies at very young ages because they will almost inevitably develop medullary, and their prevention is is removal of thyroid gland. Sporadic cases, patients tend to be older, tends to be unifocal. However, it is now recommended that even in older patients with presumed sporadic tumors, that these undergo sequencing for RET mutations. And if there is a RET mutation present in the tumor, then the patient should undergo RET germline sequencing to see if there's a mutation in the patient's germline, right? So if there's no RET mutation in the tumor, there's not going to be one in the germline. But if there is, there could be. So this is how we now do screening for MEN syndrome in adult patients. These can travel to both lymph nodes and hematogenous sites, as you can see there. All right. And then kind of finally, very rare thyroid FNAs contain cells that are extremely large and dark and I spelled pleomorphic wrong. Pleomorphic. You can see on the right here, some of these nuclei are quite small, some are quite large with very unusual looking nuclei. The cells are a little bit wispy, not quite epithelioid, but not quite spindled. You may or may not see a mitotic figure here and there. And these could be something else, right? These could be a high-grade thyroid carcinoma or some other type of neoplasm that often requires resection to find out. So there are a couple types of aggressive thyroid carcinomas. There are the high-grade or poorly differentiated carcinomas, which are essentially defined by increased levels of mitotic activity and necrosis. So you can see here, this is a very solid tumor. You can see one, maybe a couple mitoses here, and you can see this zone of pink dead cells in the middle. That's necrosis. Okay. The worst of all, right, is anaplastic or undifferentiated, which no longer looks like thyroid anymore. It looks like sarcoma. It can look like squamous cell carcinoma, very, very spindled, very ugly, very pleomorphic, very mitotically active, and often necrotic. And so both papillary and follicular can transform to poorly differentiated or high grade. And all of those can transform to anaplastic over time and with the accumulation of aggressive mutations. Poorly diff is generally on the order of sort of years to decades of survival. Anaplastic is most often, sadly, on the order of months. If caught early, patients can live years or decades. But very often these are aggressive. The patient suffers from rapid sort of suffocating type of symptoms, difficulty breathing. And these are generally non-resectable, the anaplastics, and are treated medically. So if there is a targetable mutation, which we'll get into in a bit, these can be treated with targeted therapy against the mutation. If not, it will be other chemotherapeutic type of regimens or external beam radiation, et cetera. So the mutations, right, that are known to be found in thyroid tumors. We already talked before about the follicular adenoma, follicular carcinoma spectrum, which tends to be the RAS mutations, as well as a specific variant of BRAF that is called K601E, as well as PAX8 gamma fusion. So there's genetic overlap here between benign and malignant, so we can't really tell if something is an adenoma or a carcinoma based on that mutation. We can tell that it's a follicular neoplasm. For papillary, these are specific and would not be found in benign neoplasms. So BRAF V600E, RET PTC rearrangements, NTRK fusions, and BRAF fusions are all quite specific for papillary carcinoma. NTRK fusions are treatable with tyrosine kinase inhibitors. BRAF V600E is treatable with specific BRAF inhibitors. So these are some of the targeted mutations that will be helpful in patients with high-risk cancers. Once there's transformation to higher grade, we start to accumulate mutations in TP53 or TERT promoter, which is quite common in thyroid. We already mentioned medullary would be more of a RET mutation as opposed to a RET rearrangement, right? So, we know a lot, that there's still some dark matter, right? There's still some thyroid neoplasms that have no known mutation, and the genetic drivers kind of remain unknown. But the more we know, the more we understand, and I think genetics are becoming really important in thyroid for this reason. Before I go into a little bit more depth on the molecular testing, do you guys have any other questions? Okay. So now that we know a little bit about the genetics and the biology of thyroid, I want to go back and briefly touch on molecular testing on FNA for that indeterminate category, because I think there's a lot of kind of uncertainty and unknown about this. But I think if we think about it logically, we can come to some good understanding. So there are 3 commercially available tests in the US for molecular testing on indeterminate cytologic thyroid nodules on FNA. There's Veracyte's Afirma, which is probably the biggest one. There's ThyroSeq out of Pittsburgh, and there's Interpace, Thyromere, Thygen Next. All of them do pretty much 2 things. They do some kind of gene, microRNA, or messenger RNA expression profile that sorts nodules into global gene expression profiles that are more commonly benign versus more commonly malignant. And then they have a specific panel for gene mutations and fusions that may predict a thyroid type of neoplasm, right? Some being specific to cancer and some not being. So if you have a benign gene expression type of profile and no mutations, then you're highly likely to be benign on resection. Right. And so this negative for both, right, is really, really, really helpful to rule out malignancy, because now you've taken a cytologically indeterminate nodule and you've dropped its risk of malignancy to single digit, very near 0. So these patients can now be treated as effectively benign with observation. Okay. However, if you have a positive result, whether it's the gene expression profile or the mutation, that is really, really, really variable, right? So if you have to interpret the positive or the quote unquote suspicious results with caution and really understand what are they calling positive. Okay, so let's look at the next slide. Again, if you have a negative mutation and a negative expression, this is great. This is effectively benign. If you have a positive mutation for a follicular neoplasm, like a RAS, a BRAF K601, a PAX8 PPAR, this means you are in a follicular neoplasm world. You could be benign still, you could be a follicular adenoma, you could be a follicular carcinoma, or you could even be a NIFT-P, which we'll get to in a second. If you have a mutation that is positive, that is specific for carcinoma, then we know what to do. The BRAF V600E, the RET PTC, the NTRK, or the BRAF fusions, the RET mutation for medullary, often aggressive mutations like P53 or TERT, then, therapeutic thyroidectomy is certainly indicated, right? However, if you don't have a mutation or a fusion, but you have a positive gene expression profile, that's not too helpful either. So probably you still need a diagnostic lobectomy, because a positive gene expression profile doesn't necessarily mean that you're malignant. It just means you have a higher risk of being malignant once the thyroid is resected. You could still be a benign adenoma, but your gene expression profile is like tending towards malignancy based on these studies. So hopefully that kind of clarifies what I'm looking for on the molecular test and how you might be able to counsel patients based on their risk stratification from these molecular tests. Because they will give you a percentage and be like 80% risk of malignancy, but to me that's meaningless. I want to know where is this 80 coming from? Is it because it has a BRAF mutation, or just a random positive gene expression, or is it RAS, in which case, your outcomes are completely potentially different. Does that all make sense? Okay. All right. So because NIFT-P is a relatively newer concept in thyroid neoplasia, I want to spend a little bit of time talking about what this means. So NIFT-P stands for non-invasive follicular thyroid neoplasm with papillary-like nuclear features, right? So non-invasive follicular papillary-like nuclei. All right, those are the 3 things to remember. So, if you remember, tumors of follicular cells are kind of sorted into these well-differentiated neoplasms, the papillary and follicular, and then the high grade. And then the C cells, right, are medullary, okay? We can sort these based on genetics, into the BRAF-like and the RAS-like. And this detailed information on sorting of thyroid carcinomas came from the TCGA study that was published back in 2014, the Cancer Genome Atlas, which really said, if you have a BRAF V600E mutation or a BRAF V600E like mutation, these are really, really biologically similar. They are pretty much classic papillary thyroid carcinomas. However, if you have a RAS-like neoplasm, which we already talked about what those were before, right? The PPAR gamma, et cetera. Those are completely different. They're more like follicular neoplasms, and you can almost turn on a dime, right? That black line in the middle is like, hey, we kind of converge at the center point, but pretty much there's not a lot of overlap. And if you're on one side of the line or the other, you have this dichotomous genetics and this dichotomous behavior. So NIFT-P, honestly, it used to be called a cancer. It used to be called the non-invasive, right, encapsulated or circumscribed follicular variant of papillary thyroid carcinoma because the tumor grew in follicles, not papillae. It did not invade the adjacent parenchyma, it was circumscribed, but it had nuclei that are normally associated with papillary, like enlarged, wrinkled, cleared chromatin, etc. So because of the nuclear features, it was called papillary. But guess what? If it didn't invade the capsule, it behaved benignly. So retrospectively now, these are now no longer being classified as cancer because they don't behave like it. Okay, so the formerly known as encapsulated follicular variant of papillary really no longer exists. And so I've kind of given you this chart to compare the growth pattern, the presence or absence of invasion, and the appearance of the nuclei between papillary thyroid carcinomas and follicular neoplasms, and then this overlapping group, right, where you have follicles but absent invasion but presence of irregular nuclei, in contrast to true papillary carcinomas that may or may not grow morphologically in papillae or morphologically in follicles, but uniformly are invasive, right? And uniformly have irregular nuclei. So really, if you look at PTC encapsulated follicular variant and follicular adenoma, the only essential difference is the nuclear features being round and bland or atypical and elongated and cleared. And so here's kind of a schematic of what these tumors look like. We've also learned that these quote unquote encapsulated follicular variants of papillary, tend to have RAS mutations, just like follicular adenomas and follicular carcinomas. And when you stratify them by the presence or absence of vascular invasion, it's only the ones that have vascular invasion that metastasize. The ones that don't have vascular invasion don't metastasize. Well, like this kind of looks like follicular carcinoma and this kind of looks like follicular adenoma, but with the presence of weird looking nuclei. All right. Compared to on the left, the papillary carcinomas that have BRAF V600E or V600E like mutations, whether or not they grow in follicles doesn't really matter. They have lymphatic invasion and they have lymphometastasis. So we've now been able to sort these. And papillary thyroid carcinoma, non-invasive encapsulated follicular variant, is now NIFT-P, non-invasive encapsulated follicular thyroid neoplasm with nuclear features. So if you see these diagnoses out in the world, that's what they mean, and that's how we got there, all right? Because now we understand better the biology and the behavior, and we are less afraid of those funny-looking nuclei because they are, in this context, meaningless. Does that make sense?
Yes.
Awesome. Thank you. So now on a diagnosis of NIFT-P, the patient does not have to undergo completion thyroidectomy, or radioactive iodine ablation, just close observation. Whereas in the past, the diagnosis of carcinoma would likely have prompted completion thyroidectomy, maybe radioactive iodine, Synthroid, et cetera. So really good for patient care and quality of life. Most of you know that I have a YouTube channel out there with tons of lectures, thyroid, not thyroid, salivary, whatever. So, I can send you the link, or you can find me on YouTube. And if you have more detailed stuff you want to look at, please refer to the channel as well. Okay, so now the NIFT-Ps belong here in the group of follicular neoplasms, because we know biologically and genetically that's where they live. And the BRAF-RAS score, right, can be, the BRAF-RAS profile can be used to support something that is BRAF V600E-like or classic papillary, or something that is RAS-like, which is more of a follicular neoplasm and not a classic papillary, because we know they are biologically and genetically nearly mutually exclusive. Okay. The one other thing I wanted to point out, which is important for us in our kind of collaborative work for patient care, is extrathyroidal extension of carcinomas. So bear with me, I know it's a little bit kind of out of place, but the 8th edition of the AJCC cancer staging system really only upstages the patient for extrathyroidal extension if it is evident grossly, not if it is evident only microscopically and only into fat. It has to be present grossly, and it has to be present into skeletal muscles, strap muscle. So I ask my residents and our PAs to very clearly state whether they see invasion of the cancer into strap muscles, because this will qualify for upstage to T3B. And we always want to correlate with your intraoperative surgical impression whether or not you see gross extrathyroidal extension, and therefore, it's stuck on the strap muscles, or I have to take extra tissue, extra muscle, extra whatever. So documenting that in the op note is really, really helpful for us to correlate what we see and to appropriately stage the patient. So for me, this is probably one of the more important ways that we can collaborate with your eyes and our eyes together to appropriately stage the patient. So this has been really helpful when we can match what you see to what we see. Lastly, I just want to point out decalcification issues. So, some thyroids are extremely calcified, whether in this kind of eggshell calc or the internal small calcifications of papillary thyroid carcinoma. And if this is the case, we may have to process these differently, which may take a little bit longer. So when we think about preservation of DNA and RNA and protein, our usual decalcification solution, which is hydrochloric acid, is very harsh, and you cannot do any kind of molecular testing if you use HCl. So we either will try to get tumor that is undecalcified, or tumor that we can decalcify in a gentle chelating agent like EDTA, so that we can, if applicable for treatment, patient care later down the road, we can do sequencing. So you may see some delay in some of these calcified cases because of the decalcification process, but ultimately it's better for preservation of that tissue for patient care. And so you may say, oh, well, you probably have molecular from FNA. Well, not always, because if it's diagnosed as a cancer on FNA, for example, it doesn't undergo molecular testing because it's already a cancer, right? So we therefore may actually need to do it on the paraffin tissue, the paraffin blocks, or either for diagnosis, for prognosis, or for therapeutic indications. So just kind of reminder about pathology processing in that regard. Comments or questions? All right, in the last 5 minutes, we'll talk about parathyroid, because there's not much to say on parathyroid, because it's not really a pathologic diagnosis. It's more of a clinical, serologic, and radiographic diagnosis. So just as a reminder, normal parathyroid is about half fat and about half cells. It is composed mostly of these chief cells, some oxyphil cells or oncocytic type cells, and then occasional cytoplasmically clear cells. Parathyroid disease is generally clinically hyperparathyroidism, right, with high levels of calcium and parathyroid hormone serologically, which could be due to an adenoma in a single gland, which could be due to secondary hyperplasia in the context of usually chronic renal disease, where you have electrolyte abnormalities and essentially all your glands are out of whack. What they are clinically is they're enlarged by weight, so they're heavy, and they look hypercellular to us on histology. Now, this is a classic example of an adenoma that has a nice rim of normal parathyroid and a tumor in the middle, but not all of them look like this. And the histologic features of adenomas and hyperplasias are extremely overlapping. Therefore, I don't really diagnose adenoma versus hyperplasia. I tell you whether it's heavy, I tell you whether it's hypercellular, and you know whether the intraoperative parathyroid hormone has gone down and whether you have the lesional tissue out or not, right? And so intraoperative PTH, I think in these cases, is becoming much more important than what I can tell you. However, what I can tell you is if a parathyroid neoplasm is atypical, meaning does it have a lot of fibrous banding? Does it grow in large nests and sheets? But in the absence of invasion, these are atypical features. When can I call something true carcinoma? Well, you basically need destructive invasion, whether it be, infiltration into the adjacent thyroid gland, vascular invasion, perineural invasion. Then I can make a diagnosis of carcinoma, or of course, if it metastasizes, but that's usually, usually patients with parathyroid carcinoma don't present with metastasis, usually present locally with hyperparathyroidism. Something looks unusual, we diagnose it as atypical or malignant, and then later on it recurs, and later on it metastasizes to things like lung, et cetera. So parathyroid carcinoma is extremely rare, but if you are suspicious for it intraoperatively, again, this is where we can work together. Is it very adherent to the surrounding tissues? Is it hard to get out? Do you have to take the thyroid lobe out? Those are things that are more worrisome for carcinoma, and we work together in those cases. Lastly, there's this disease of parathyromatosis, which is thought to be only related to post-operative seeding of parathyroid tissue during prior surgery, where these small nests of hyperplastic or adenomatous parathyroid kind of leak out into the tissues of the neck from a previous surgery. And now you get these multiple small nodules in the tissue, but without, vascular invasion, without perineural invasion. It's just local kind of spread and seeding. And so this can occur in most often secondary hyperparathyroidism, associated with renal disease when you have lots of multiple abnormal glands in the neck. These usually don't metastasize or, do anything necessarily poorly to the patient, except for they can recur, they can be hard to excise, and they can cause, hypercalcemic states. So just beware of possible parathyromatosis if there are multiple little nodules in the neck as well. Oops. So yeah, so that was it for thyroid and parathyroid. I hope that was helpful. And I'm glad we got to record it. Any questions or comments? Okay.
That was super helpful. Thank you.
Oh, you're welcome. Thank you so much.